Okay. Good morning. This is Colleen Lavelle from Jennings Center for Older. We'd like to welcome you to our training session on AgeNet-OASN Managed Care Metrics. We'll be presenting with Cindy Saunders from Jennings Center for Older Adults and Barb Barnett from St. Augustine Manor. Just wanted to get started by talking about our partners. As you can see on the screen, we've been working together on creating our managed care partners we want to show our quality to. And we have OASN. I'm sure there's many members on the webinar from that network. That's the Ohio Aging Services Network, representing leading age members in 3 regions in Ohio. And we have AgeNet members, which are about 11 of us here in Northeast Ohio. Members are in the room today with us. And we have, of course, Leading Age, where this all with trying to get our metrics together. And then CPMT is our performance measurement company that is collect our data and our metrics and so that we can do some benchmarking. So with that, we're going to start our training session. Oh, well, we thought we'd start out with a nice quote to get us in a humorous mood about data. In God we trust, all others must bring data. In this changing landscape of healthcare delivery reform, we all know that this is really important here today to get us started with this journey. So just a little bit of context. Actually, about a couple years ago, I think Leading Age started out with a set of metrics that a group of us from all on those metrics. And then about a year ago, we decided, at least in Northeast Ohio with AgeNet, that it might be a good idea to make sure that we're having consistent data, that we can streamline it as much as possible, and that we retrieve it from reliable, validated tools. So actually, Gina Prosser at Montefiore actually was the one that started to lead this effort, and then I took it over as the quality chair a few months ago. So So what we're going to be doing then is that there were these leading age metrics that people have been entering in, but now that we've sort of revisited it, you'll be seeing these new metrics, and hopefully many of you have copies of it. But we'll begin to report the new metrics on July 15th. CPMT, others are not, like I said, have been using it for a while. But if you are new to it, the chairs of the quality committee can orient you to that. And then I'm going to also be showing you some training webinars that CPMT, Paul Ringforst, will be doing, and you'll be seeing that those are available to you. So as I said, these system will help us to benchmark. So going forward, a function to be looking at these reports and seeing how we're all doing, and hopefully helping us to raise the bar on people that are high performers in some of the metrics and share best practices. So as you all know, I'm just kind of, the whole reason we're doing this is it's really critical to show our performance that's going to be the way we get reimbursed. And just to say that this is a place to start. It's not, written in stone, these measures. Over time, we'll see that payers or other partners may want other metrics that we can add. We might take some away, but it's really just a place to start. So these are the metrics. There's, I believe, 12 of them that we decided we were going to start with. The first goes through the nursing staff hours, just to show what our capacity is for delivering care. And you can see we have nursing staff hours for short-term, long-term. We have nursing staff hours for short-term. And then we have RN hours for short-term, long-term, and short-term. So just some things to keep in mind. On the CPMT template, which I believe was emailed to many of you, it's a landscape table type of document. There's some reporting time frames in there that we're going to just tweak a little bit to reflect what I've got here up on the screen. Up on the screen, we got a little bit more specific on just setting some dates. So we'll be changing that for those of you that have that in front of you. So there's monthly metrics and there's quarterly metrics. The first ones we're going to be showing are our monthly metrics. And we decided just to have a date that fit all the metrics, and that was going to be the 15th of the second month following the review period. So for the month of May, you can see an example. We would be reporting data in July 15th. So that's the second month following that review month. So just some guidance. We want to be sure that we're including direct and indirect nursing staff, so it would be all your administrative nurses, MDS nurses, all of those people. We want to be sure we're actual hours worked, so we're not including PTO time. If this particular metric, we did say to break it down in short-term, long-term, and for people that don't have a distinct unit that you would count staffing on that unit for skilled nursing, then you would just have this be 0. That's just a question that came up before. Then we have our 30-day unplanned readmission rate. We have this for short-term and long-term. Same reporting period, date that you would report it. And the thing that we're emphasizing is the use of a hospitalization tracking tool that Barb is going to be going over later in the session. And the tracking tool, there's 2 of them that are virtually the same. One is the Interact Hospitalization Tracking Tool, and the other is the Advancing Excellence Tracking Tool. They're basically the same thing. The Advancing Excellence have a few more quality questions on their Excel spreadsheet. So we'll be talking about that a little bit later, but the point on this is that if you use that hospitalization tracking tool, you'll be able to get this data to report on the 15th of the second month. What this does, just so you understand the logic of the way they calculate it, is they will take the people that came into the facility, that were admitted into the facility for that month, and then they will track them, those individual people, for 30 days. And that's why we have to wait that long, so that we see that if they did go to the hospital. Then we have unplanned observation stay, because we want to track those separately, because we don't want to be those to count as admissions or readmissions to the hospital. So we track those separately. And again, those two hospitalization tracking tools will give you that data. And then there's also, just to give you a little, the guidance on here is the way that the tool tracks this is it adjusts for census and the number of days in the month. And so the way they do that is it's often expressed in admissions per 1,000. So 3 observation stays per 1,000 resident days would be how it gets, you would talk about it. So, or you could say 3 observation stays every 10 days. It's just the way that it's often expressed. Same with the emergency room. We want to just take a snapshot of that for the month. Return to community is another monthly reporting. So that includes just, we're tracking everybody that comes into our short-term skilled and returns to the community. And as Barb and Cindy are going to talk about later, some of this data, you need to go back and figure out what your process is to determine, where they went. And all of us have different systems and ways to gather that information. So, and that's anybody that returns to any kind of home setting, whether it's assisted living or an independent living apartment. And the denominator on this one is includes everybody who became unskilled for any reason, including death. So then the others are quarterly, and they're coming right off of reports that we're all very familiar with, and that is one of the things we wanted to do, was to streamline this information as much as possible. So falls with major injury, high-risk pressure ulcers, UTIs, and newer worsening pressure ulcers are all obtained from the CASPER report. And the reporting period for that is the last day of the month that follows the review period. So, for example, for the quarter of January through March, we would report that at the end of April. We want to be sure we're capturing everybody in that quarter, because I understand sometimes it takes a while to be sure you're capturing everyone. So that'll be entered on April 30th in this example. The next ones are patients or residents who were assessed and appropriately given the flu vaccine, and then the other is who were given the pneumonia vaccine. And again, they would also be reported the day of the month following the last day of the month following the review period. So again, these will be obtained from the Nursing Home Compare website 5-star report, because those are, again, easily captured and reported. I understand that sometimes the example here shows from January through March, we want to enter at the end of April. And we're doing this so that we all are kind of in sync, and we're looking at data all that we've collected in the same time period. So even though there may be data that shows up that are from earlier months, we just want to report what's coming up for us on April 30th. So that's that portion of the of this training session. And the next thing I want to talk about then is this hospitalization tracking tool. So we would like everyone to use the Interact or Advancing Excellent Hospitalization Tracking tool to report those three metrics: the 30-day, emergency room, and observation stay visit rates. So the tool, it is really the gold standard out there for tracking hospitalizations. And as some of you know, Interact has a lot of other quality improvement tools that many of you are probably using, and this is one of them. And what it does is it provides clear hospitalization rate definitions consistent with evolving definitions used by CMS. CMS doesn't have yet a measure in how to measure 30-day hospital readmission rates for skilled nursing facilities yet, but it is coming. And there's other organizations, the National Quality Forum, are all thinking about what this is going to be, and I'm sure that they're consulting with Interact on that. And so anyway, the utilization of this tool will also ensure that we're accurately and consistently reporting the information to CPMT. What we're going to be going over is the tool, and actually Barb's using the Advancing Excellence tool, which, as I said, is virtually the same as Interact. And she's not going to be actually talking about some of the quality improvement pieces of that tool. We're basically just going to be going over the fields that are required to track our 30-day hospital readmission rate. So I think with that, I'm going to turn it over to Barb.
Hi, I've been using this for about 2 years, and when my administrator told me that I needed to do this, I was completely overwhelmed. In the beginning, it takes a long time to set up, but then once you have it up and running, it doesn't take very long. And just the actual data entry doesn't have to be a registered nurse. When it comes to the QA piece of it, the nurse has to, but I have a couple of different people that help me do this, and I'm just going to tell you how I set this up, because one person doing this would be a lot of work, but I have admissions helping me out on this. So I just want to go over this with you. I think everybody should have the download. There's a Q&A section. Any question that you have, basically, you can just click on where it says Common Q&As, and the answer is right there for you. Okay, the first thing you need to do, though, to set this up is do your drop-down list. So I did an example of this for you. Oops, up to the top. So this is the part that takes the setting up. Okay, so basically what I did was set this up, and you just go into the drop-down list and put where the residents are admitted from. Okay, so either home, AL, another nursing home. I put, a whole bunch of hospitals in. And then different clinicians. So if you have nurse practitioners, your doctors, you just add those in. And then you have to start with all the residents. Okay, so I would probably start maybe with April's residents, get your current census, put every resident in, and then all the different insurance plans. So that's your first step. So then what happens is and my admissions department does this piece for me. So they would go in and they would type in the resident's name, the hospital discharge date, the date admitted to the nursing home, and then it automatically populates the day of the week for you. And then the status on admission, if it's post-acute or chronic, which hospital the resident came from, their insurance plan, was a structured communication tool used to receive information from the hospital, was it adequate, and then was there a medication reconciliation done? Now, I don't believe Interact has those last couple of questions.
And we're not going to be focusing on
No.
this. I mean, obviously, if you want to use this for your quality improvement, that's really great. But just so you know, we're just going to be focusing on the columns required for the 30-day readmission data.
Correct. So my admissions department puts all that information in because they know that upon admission. So then where I come into play is the transfer log. Okay, and this is where everything, all the numbers come from. So this is just an example of what I did. I would come in, I would put the resident's name, their primary symptoms leading to a transfer, the purpose of their stay, what their payment was, the date of the hospital transfer, the time, the doctor ordering it, the symptoms leading to it, the diagnoses that led to the transfer, and a lot of times we call the hospital and we have to get that. The clinician or the primary contributing reasons for the transfer, and these are all drop-downs, okay? So like if you look at the drop-down keys, it gives you ideas. And then a lot of times, you know, if it's not there, I just put other. So all of these have drop-down lists. And you just add them in. If you keep going across, then the outcome, was it planned? Was it unplanned? Was it just, and then like the outcome, was it an emergency room visit only? Were they admitted in observation? Status uncertain or other? If they're in observation, it really makes a difference in your numbers as opposed to if they're truly admitted. So then the rest of these we don't even have to look at because that's just part of the QA process. So then from those, what you put in, when you go to the month, this is what's going to print up, and this is where you're going to get your data for the metrics. So basically all of the questions that the metrics are asking for are right here, broken down by month. Now, Lee can tell you here, like, okay, so for January 2014, you're not going to be final until you've completed your transfer log through March 3rd. So basically, it's always 30 days behind. And then all of your answers are going to be within this report. Let's see. What else? So basically, it's pretty simple. It's the startup is hard, but once you get past the startup, it's very easy to maintain.
To note about the drop-down list that you have to create initially before you get started, if you already have that information in other systems or Excel or any sort of electronic version, you can cut and paste into this document, so that will save you a lot of time. And then those drop-downs are used on the registers, on the admitted with discharge and the transfer log, so that the names of your residents always appear the same and the names of your physicians, et cetera. So that's where those drop-downs come into play.
You know, another important thing to remember is the census tab. And my admissions department does this for me. So, because this is where they populate the resident days. So that's you need to have these numbers before you will get your actual numbers for your metrics.
I think we can open it to questions.
Okay. Do you want to talk a little bit about the data collection? We're just going to give an example on, run through how this really works practically.
Okay.
Maybe Cindy, you can talk about it a little bit in terms of where we get our data from. Like, how do we find out if a person went to the emergency room or if they were on observation? That becomes a little bit of a,
right.
information journey where you got to find that from.
Right.
So
I always have my admissions department call and speak with the case manager, because even one person being in observation as opposed to admitted makes a big difference in your numbers. So my admissions department always calls and double checks and lets me know, were they in obs or were they truly admitted? Because we've had some people remain in observation for 3 days. You think they're admitted after three days, but sometimes they're not.
mhm.
So my admissions department always calls, speaks with the discharge planner or the case manager, and double checks were they truly admitted or not.
What we did is, we're in the transition of going from paper to electronic with our 24-hour report. So what we did in the meantime to that supervisor's 24-hour report is add those columns on there so that when they're completing that report, if they get that information, they can add it to that report. So every morning, when that report is circulated, I can take a look at it and see, who went out and if they were admitted or there for observation or returned because it was an emergency department stay.
This system will automatically tell you who's, at risk for going back out within their 30-day period. It will, okay, like if you see like my yellow here, these people are at risk for going back out to the hospital. And
But
then
they're within the 30
they're within the 30-day window,
Mhm.
exactly.
So you actually focus on those people quite a bit.
Correct. So what we always do is I always give, shoot off an email to the unit managers, hey, watch these people, do extra assessments on them, get the nurse practitioner involved if you see anything going on, so we can try to keep the residents in the building and not send them out.
So I was saying before that we wanted to get this tool up and running for everyone for the hospitalization metrics. I don't want to minimize the importance of this actually as a quality tool too. So, our quality committees will probably be looking at the possibility of everyone using the other aspects of the tool too. There's the quality improvement tool that Interact has that will help to answer some of the quality questions on here. Why did someone go out? What were their symptoms? Those kind of things. So I just don't want to minimize that aspect of the tool as well.
Can we click on that?
Yeah, it does do a lot of different things too. It'll graph your 30-day readmission rates. It'll give you a whole bunch of different numbers. And then what you can do is, what we do for marketing a lot is you can break it down by hospital, by insurance plan. And it's not going to let me show you here. But over here in your tool, there'll be a drop-down key, and you can break it out a whole bunch of different ways, by hospital insurance plans. And then this is another aspect that tells you, where your admissions came from, transfers by time of day, which doctors are sending the most residents out. So it graphs it pulls information from every which way, and we use a lot of this for QA.
And I believe Leading Age Ohio is having a workshop, is it in June, on Interact.
Mm-hmm.
So they'll be going over this as well as some of those other tools in that program. Okay, so accessing this tool, it's available on the Interact website, and I believe that's, if you just Google it, you'll be able to find it.
Mm-hmm.
I believe it's also on the Advancing Excellence website, so you should be able to get it there. Before I forget, I'm going to switch over to the CPMT, because this is the other interface that we're going to be needing to utilize. So once we get the data for our metrics, all 12 of them, oh, look at that. It's this right here. It was up already.
Oh, sorry.
I just wanted to show you the dates that are available, and I'll forward this information to everyone. But you can see there's one coming up on the 21st, June 2nd, June 12th. I don't know if you want to write any of these down, but the 17th. So there's several options, and like I said, I'll send this to everyone via the quality chairs. And I did want to mention Vicki Bartlett and Tammy Cassidy are the quality committee chairs for OASN. and they'll be your interface for that network. And then I can be the contact person for AgeNet. So, should we open it up for questions? Let's open it up, the chat thing right here, right? Is that what I do? And then if you could, anyone that has questions on the webinar, please enter them in and we'll answer, hopefully. And then anybody here, we said we were just going to kind of bring the microphone to you, or you can come over here and ask your question. Or we can repeat it. Anybody have any questions here? Can they hear it?
Oh, there's no audio anymore.
There's no audio anymore. Oh. John, can you help us? When did that go out, you know?
Well, that's the only person that should be bombarded with email or with chat.
He's the only person.
So ask them to send a chat if they're no longer able to hear. Folks on that.
Oh. Okay, we don't know if we lost audio here, so apologize for that if we did. Or if you can hear us, would you please send a chat?
Here we go.
Oh, we got some coming in. Okay. There's no audio anymore. Hopefully we're back. Okay, thank you. All right, so, any questions? How do you want to do it? Okay.
There is one question we can answer now.
Okay.
Can you send the quality measures to me? Yeah, we will send out the quality measures.
Yeah, I will. Once you get to the CPMT website, you'll be able to see them there, but I have them like in a hard copy too that I will send to you.
On the hospital tracking form for the residents who are at risk, once they are past their 30-day period, is there any other method? Does it go anywhere else where these people still are potential? Or is there anything else that we can track them with within the hospital tracking tool?
No.
Okay, they just go away.
It doesn't go away, it's always gonna stay there.
Mhm.
So when you see, say, somebody, is on day 45, when you go and put them in the transfer log, it will come up the last time they were in the hospital.
Okay.
It just won't count against you.
Okay, and then it'll turn from yellow. So
After-
once the 30 days are up, do you go back in and do it?
When they're within their 30 days, they'll be yellow, but once their 30 days is over, the yellow goes away. Okay, so then if somebody goes back out and then comes back in, then they'll be yellow until their 30 days are over.
Okay, one of the questions was, will we be posting the slides? And the slides will be emailed to everyone. And then we have a question to go over the census section in more detail. Where is it at?
Okay, so for the census, post-acute care type, like I said, my admissions department does that, and that's just the number that they pull and they calculate for the average for the average for the month, and then the average daily census is what they pull also, and then actually everything else gets calculated for you. So you just have to put in the two numbers, the post-acute care type and the chronic long-term care average census, and then the rest is all taken care of.
Back. Sorry about that.
No.
Maybe you could let us know if you can hear us now. Okay, thank you. We're on. Okay, let's ask the question again. The question is that basically the nursing home compare information for those vaccinations are old information from last year. And so I think it's a good question. Don't we want more current information on these? So I think what we'll do is we'll maybe take it back to our quality committees and have some discussion on how we might be able to track more current information in a streamlined way to be sure we're all doing it the same way. So that's a great question. Is reporting required for every SNF regardless of size? I would say yes. I think this is pretty important and we'd like everyone to do it. Let's see. How do you share the tool amongst users? And I believe you're talking about the hospitalization tracking tool, so I'll let Barb answer that.
I just asked my IT department to put it on a shared drive at work for me. So basically that's what he did. I have a shared drive between myself and the admissions department where we both enter information into it. So I don't know if that's possible for everybody, but we managed to do it that way.
Okay, we have another question. This is another question. Is the census sheet in Interact also? I believe it is.
Yes, it is.
It is.
It is,
Okay.
yes. And we have one question that we skipped, and maybe this is more of an IT question, but I'm wondering if you can access this tool from more than one location. And if I understand the question right, if it's on a shared drive, then yes, anybody that has access to the shared drive can get into the tool.
Like I can't access it from home though, because it's saved on my computer at work, so I can only access it from work.
You do want to make sure if you do put this on a shared drive that you protect this and limit the amount of users that do have access to only those that need access, because it does contain a lot of personal health information. Any other questions?
Okay. Did you have one? Does somebody have a question here? No. Okay. All right. Well, thank you for joining us. I think we're finished. Again, let's follow up with the quality committee chairs if there's any further questions. And we thank you for joining us today, and we thank you for working as team members in our striving for quality by doing the metrics and reporting them in the CPMT website.
We do have a couple more questions.
A couple more questions? What? Okay.
How does the site relate to Interact?
Relate to Interact. Trying to understand the question. Then is the information. What is that?
Is the information example hospitals in your area placed on the tool? That's a drop down that you set up.
Yeah.
Okay, go
So
ahead.
let's answer the last couple questions. The information, for example, the hospitals in our area, is that information that's placed in the tool? That is information that you put in the drop-down list when you set up the tool. And you, again, if that is something that you have in another spreadsheet or electronically, you can cut and paste. Otherwise, you are typing in your hospitals, your residents, your clinicians, and your insurance plans, so that you can use those drop-down lists in the admitted with recent discharge and the transfer logs, so names always appear the same.
Okay, Adam, the question of how does this site relate to Interact? Okay, trying to understand that question. This tool is Advancing Excellence, and the hospitalization tracking tool is virtually the same as the Interact hospitalization tracking tool. We just happen to be using the Advancing Excellence tool right here now. The other site that could be referring to is the CPMT website, and that's basically the data collection website for all of our metrics. So I hope that answers the question.
We have one more question on the admitted with recent discharge lab. What is meant by status on admission to nursing home? Oh, let's go back to that tab. They're asking if it's a short-term stay or long-term stay. And that's a drop-down. There are only two.
There's two options. So it's either chronic long-term or post-acute. And then when you click on the drop-down, it also goes into more detail and gives you definitions of what they're looking for. So basically, chronic long-term care if they're not on Medicare Part A.
The question, how do we receive these tools? These tools can be downloaded from the websites, and when we email out the slides, we'll include those websites for you. Both the Advancing Excellence and the Interact websites have the tools. They're very similar. There's a few additional columns in the Advancing Excellence tool that are not in Interact, but for the most part, the rest of the spreadsheets are exactly the same.
Okay, I have a couple more questions. Does this tracking tool for hospitalizations address tracking diagnoses? For instance, for heart failure, pneumonia, MI?
Yes, it does. On the transfer log, where it asks you to give the primary signs and symptoms leading to the transfer, and then it'll go into diagnosis. It's oops, one over. They're all drop downs right here.
And that's the diagnosis for why they're being treated in our organization?
In the hospital.
In the hospital.
Mm-hmm.
I mean, why they came to us from the hospital?
No, this is what their admitting diagnosis to the hospital was.
When they went into the hospital. You mean when we transferred them out again?
Yes. So
Okay.
we transferred them out, and then when they got admitted there, what was their reason for being there?
Okay. What was their reason for being there when they were transferred out?
Let's do these questions first.
Okay. We have a couple more.
Yeah. Do we need to input data into both the Interact and CPMT?
Yes.
Yes. The Interact or Advancing Excellence tool is what will give you the statistics that you then will enter into CPMT. And if you received the metrics spreadsheet or worksheet, it'll tell you in the column with the specific metric where that data comes from. So if it comes from an Interact or an Advancing Excellence tool, you'll see that. If it comes from a different source, you'll see that on the spreadsheet.
Yeah, and it's basically just a field where you will put a percentage, literally. You'll just put the percentage into CPMT. Okay, another question. For those of us who are using CPMT now, do we report old definitions until July? I think what we said is that we want to start tracking May data using these metrics. So I would say that we would start using the new metrics beginning July 1st, July 15th. Okay? Yeah, right. That's right. Okay. So does that make sense to everyone? Yeah. No, you just start using this tool for till July 15th. Yeah, 15th. Right, like for May, like the old definitions. Hadn't thought that out, but I don't see why we need to necessarily, unless someone else thinks we do. I know that Paul probably wants me to say that the old historical data will be moved in June, I believe. I think that's what the memo said, so you will still have access to it, but it'll be in the historical section. Okay.
We have one more question.
Okay, so the question is, so you get the diagnoses from the hospital, H&P, or where is the best place to get the official diagnosis to put in this area? What if there is more than one diagnosis? I just go with the primary admitting diagnosis that the hospital uses, and that we usually call and ask what that is, or when they do come back on the transfer sheet, that's what I take.
Is that it?
Last questions that people want to present? Okay, one final clarification. Yes. July 15th. Yeah, just to restate and clarify, we're going to be starting to use one of these hospitalization tracking tools using data from May 1st and then through the end of May, and then we'll report that data July 15th.
So, May 1st.
When do we start using Interact? May 1st, yes.
Go back and populate your spreadsheet to May 1st, beginning with May 1st data. And then is this question you can answer?
Is that answered? The primary diagnosis can be different than the discharge diagnoses. You still want to use us? Do you still want us to use the primary hospital admitting too? So,
Yes, use the primary. That's what the definition states to do. So enter the primary diagnoses leading to the transfer.
Okay. Any other final questions? All right. I'd like to thank everybody and thank OASN members and the quality chairs for collaborating on this effort. And we communications in the future.